Today we're going to provide a webinar that discusses the patient chart to give you some insight on how to set up that chart and be prepared for your site survey visit with us. Today, the purpose of this training is, again, to assist you in having charts that are compliant, organized. So we're going to review today on how to set up that patient chart, give you an example. And then we're going to talk about the required documents that you need to have in your patient chart. And then we're going to provide you with some explanation on those documents. So again, if you understand those documents and what they're used for, it'll give you a better understanding of why you need to complete those. First, on the outside of your chart, and again, remember all of the things that we're going to tell you on this webinar are inside your policies, and that it's imperative that you're following your policies. That's one of the things that the site surveyor will look for. And those requirements for your chart are based on not only the Medicare requirements, but also the CHAP requirements. So on the outside or front of your chart somewhere, we want to see your patient's name, the medical record number of your patient, the DNR status, any allergies, and then also the disaster code. Now, the medical record number, if you're not going to be using software that automatically assigns a medical record number, you're going to need to keep a log that we provide to you, and you're going to need to assign your own medical record numbers. You can use whatever numbers you want. I recommend maybe starting with 101, but you can do any combination that you want. But once a medical record number is assigned to a patient, that stays their medical record for any other times they ever are serviced by your agency. And again, remember that medical record number is important because that's the unique identifier for the patient, so that you don't have to use their name and violate HIPAA regulation. So part of the chart setup example is that on tab 1, we want to see the intake referral form. We want to make sure that's completely filled out. Now, when you first get an intake or referral for a patient, you may not have all that information, but at some point in time, all of that information should be filled out on that intake referral form. We also are looking in that chart for any copies of history and physicals that you may have gotten from your referral source. It may be a hospital, it may be a doctor's office, it may be a rehab center, it may be a wound center, whatever that referral source has shared with you about that patient should also be under that tab 1. You also have patient information contact information there, and that's particularly important. That you understand the emergency contact and who you're going to call if you have an emergency with a patient. And it also identifies their disaster number. It's either going to be 1 through 4, or in Florida it's 1 through 3. But again, those are forms that's in your admission packet that we want you to complete to identify at what priority, if you had an emergency, they would be contacted. The other one under tab 1 would be your consents. Again, these consents have to be signed. If the patient is confused or is not capable of signing, then you're going to need to determine if there's a power of attorney or a healthcare surrogate that's going to sign the consents. And really that should be asked and squared away on the referral. So, you need to know that before you get into the home. And again, you shouldn't be a caregiver, a nurse, a therapist should not be touching that patient until that consent is signed. Because if something happens and you don't have consent to touch the patient, then you could be held with battery. Also under tab 1, those consents, we have a list of those consents here. One is the consent for treatment financial agreement. Again, you're going to identify on that form the services that you're going to provide to the patient, whether it's nursing, therapy, home health aide, social worker. And you're also going to fill out approximately how often the patient could expect to see those services being provided. 2 times a week, 3 times a week, once a month. If you're billing Medicare, under the tab that, or the column that says how much the patient would be responsible to pay, for Medicare it's going to be 0 or no charge. Because again, under Medicare, you're accepting payment in full for those. There's also an authorization agreement and acknowledgement form that the patient needs to sign. And in your patient information and admission packet, any of these forms that the patient signs, we have duplicated. So you will bring the signed copy back to the office to put in the chart, and the unsigned forms where we've indicated the patient doesn't have to sign, that one stays with the patient. Also, there's an advanced directive acknowledgement, and HIPAA talks about privacy rights. The patient signs that as well, and they should be indicating to us whether or not they have an advanced directive or a living will. If they've indicated that to you, our requirement is that we request a copy. They don't have to give it to us, but we do need to request a copy that's provided to us. If they don't provide it to us, then we can't follow it if we don't know what that is. Also on the HIPAA, if the patient indicates to you that they have certain information they don't want disclosed, or they don't want certain information disclosed to particular individuals, and then they need to mark that on that form as well. And if they mark that on there, then you as an agency need to make sure that you abide by that and respect that. We also provide the patient a patient rights and responsibilities. Again, they're going to sign that they received those, and then the copy of that's going to stay in their home folder. And that's really important that that stays in there, because during the survey, the surveyor will look for that. There's a form in there for a home safety assessment, and that should be completed on the first visit of the patient. And part of that is that we're identifying if that home is safe enough for our caregivers and the patient for home care. Under tab 2, that's where you're going to put your physician orders. That's also the 485 will be there, any supplemental orders. And again, we want to see the most recent on top and then go down to the bottom. Don't forget, too, that you need an order to evaluate and admit the patient to home care. So a referral in itself is not enough. There actually has to be either a written or a verbal order from the doctor that he's given permission for home care to go out and evaluate the patient. Reminder, too, that orders need to be signed within 30 days of the time that they were written. That includes the 485. So for the 485, it's going to be within 30 days of the start of care. That's going to be the date that you put in box number 2 on the 485. And be familiar, too, that some states have sooner time frames. So you need to be familiar with your state as to if you fall under that 30 days that you need to comply with. Tab number 3 will be your medication profile. Again, we recommend that either if you're not using a software for your medication profiles, that you're using the form from MedPass. Some of the items that we look for on the chart audit and that the surveyor will look for, number 1, that all of the drugs that the patient is on, including over-the-counter, oxygen, herbs, supplements, IV flushes, any of those things have to be on there. They need to have a drug classification identified to each one of those meds, and also any possible side effects that those drugs or medications might have. You should also be designating whether or not those meds are new, changed, or LS, which stands for long-standing. And again, if it's a new or a changed med, that's going to support teaching on your 485. If it's a long-standing, it won't be teaching necessarily, but you could be assessing for side effects and interaction with some others. When you're doing your medication profiles, make sure that the start date on your medications are not the date that you admitted the patient. They need to be the date the medications were started with the patient. And the patient may not know an exact date for some of those meds. So if that's the case, you can put an approximate year, 2006. If it's a long-standing meds, 2006, 2000, something like that. Again, all those meds should not be listed as started on the day you admitted the patient. If there's a change in a medication, there needs to be updates to the med profile in the patient's chart. It needs to be documented in the nurse's notes, particularly if there was teaching done, and there should be teaching done. Also, the medication profile in the home and in the office needs to be updated. And there should be also an order, a physician's order written for that medication that has been changed in the home and supports that change. Again, when the surveyor goes out to do the site visit, she or he, before they make that site visit, is going to make a copy of that medication profile that's in your chart in the office. And when they go to the home, they're going to match up that one to the one that's in the home. And they expect them to match exactly. If they don't, then you're going to get a deficiency on that medication profile. So again, you want to make sure they're up to date. And as the medications change, you want to put the most recent one on the top. Tab 4 is where you're going to put your OASIS. And there should be, and there probably will be, multiple OASIS sets. They should be in that chart in the order that they occurred. Start of care, the OASIS C1 would be on the bottom, and then any other additional OASIS would be on top of that. You also are going to include your clinical notes. The clinical notes should be, again, the most recent on the top. And all of those notes should have legible signatures and titles on them. And even titles of the home health aide needs to have a title on their note as well. You will get a deficiency if the titles aren't with the signatures. Missed visit notes, if you have missed visit notes, again, the frequency that's on your 485 when the surveyor is looking at your chart, they're going to look for either a clinical note or a missed visit note to validate that you've followed the frequency of visits that the doctor's ordered on the 485. So anytime that you can't make a visit for whatever reason, you need to do a missed visit note, and that needs to be sent to the physician so that he was notified. He doesn't have to sign a missed visit note, but he does need to be notified, and you need to keep the confirmation that shows that you did indeed notify him. Missed visits are usually because the patient refuses, the patient's not at home, the patient's at the doctor's office, any of those types of things that would cause a missed visit. The clinical notes, let's talk about those a little bit and what we want to see in those notes. And the note that we provide you, and most all of the notes in any of the software that you're going to be used, has these bullet points in them. Usually what we see, though, is when we audit notes is that they're not complete, and they need to be. And this is particularly important once you start billing Medicare. This is going to be the only proof that you have to Medicare that you followed the 485 and that you deserve to be paid for that visit. So the first thing and the most important thing is the homebound status. And we would like to see at least 1 to 2 reasons of why that patient's homebound. Usually that they're short of breath, It's a taxing effort to leave home. They have an assistive device. They're on oxygen, some of those things. But like I said, at least one, we prefer to see at least 2 reasons why they can't leave home for care. We want to see, and on every one of your notes should be a skill. And that skill may be teaching, or it may be a task. But there has to be skill on every note. And even for these first 10 that you're going to do for Medicare, and you're not charging Medicare, they all must have a skill in them. A home health aid is not a skill. Filling a med box is not a skill. Drawing blood, that's not a skill. Now, you can do all those things while you're there, but there needs to be teaching or something other than those items that I mentioned before for the patient to qualify for a skilled visit. Any teaching that's done or treatment that's done, there needs to be a repeated or a patient's response to that. Either that they repeated or verbalized understanding, or they demonstrated whatever the task was, changing a dressing, measuring a JP drain, whatever those are, that needs to be documented. The progress to goals needs to be documented on every note. Again, Medicare's expectation is that this patient, through visits and home care, is going to progress and get better and meet whatever the goals are on the 485. So again, you have your clinicians reference back to whatever goals they put on the 485, and that they can document that the patient's working toward and meeting those goals. If the patient's not meeting those goals, then that plan of care needs to be revised. Either the interventions or the treatments need to be switched up so that the patient ultimately can meet those goals and be discharged. And then lastly, we want to see that there's care coordination. And that can be with a doctor, with another nurse, a therapist, a home health aide, the family. But again, that should be documented on every visit, that there was some coordination of care. Tab 5 is where we would want to see your home health aide notes and plan of cares for those. It also might be a homemaker companion. Again, the most recent plan of care notes need to be on top. And again, the one thing that we see on a deficiency, frequently see a deficiency in regard to this part of the chart, is that the plan of care doesn't match the notes that the caregiver turns in. So the home health aide is marking things that aren't on the plan of care, or there's things marked on the plan of care that the home health aide didn't mark off. So these notes, if you're going to use a home health aide for your survey, one of your 10 survey patients, you need to make sure that someone in the office is looking at every one of these notes and making sure that they match exactly with the plan of care. And then if not, there needs to be some documentation on why that didn't happen, and that the home health aide notified the office that she or he wasn't able to follow the plan of care. Very, very important. Tab 6, we want to see your care coordination notes in there. Those would also be communication notes, progress notes. If you do case conferences, your 60-day summaries. One thing about your 60-day summaries is that those have to be sent to the physician. The physician doesn't have to sign the 60-day summary, but you do need to keep confirmation that those were sent to the physician. Same thing with the discharge summaries. You want to make sure that the discharge summary was sent to the physician and that you have that confirmation. And again, you're going to have probably a combination of discharge summaries and or OASIS discharges if you've got more than one discipline and they're seeing the patient. But again, make sure that you can show that the physician was notified of the summaries. Tab 7 is a miscellaneous section. Labs, you can put labs there, any other reports that you might have for the patient, any education materials that maybe you've provided to the patient. We recommend that you also put a copy in the chart so you always have reference and proof of what you gave to the patient in writing. as part of your education materials. One of the forms that Medicare requires and that you need to be familiar with is the Advanced Beneficiary Notice of Non-Coverage, or also what we call the ABN. This notice is given to the patient when we've identified that the patient is going to be having a service provided that Medicare is not going to probably pay for. Usually that's in the case that the patient's not homebound. That's the normal time that we see an ABN. So for the first 10 patients that you get, if you have patients that are not homebound, say they're not Medicare patients, they're not homebound, you can still use these patients for your survey, but you need to make sure they've signed an ABN. Even though you're not billing Medicare, the surveyor will want to see that you understand the process and that you have signed this ABN with the patient, letting the patient know that because they're not homebound, that they don't meet Medicare requirements for home care. Also, if the patient's needing services that aren't considered medically reasonable and necessary, if they're custodial, and that usually comes that they need a home health aide, but there's no other skilled service in there. Medicare won't pay for home health aide services if there's no skill in the home. And then lastly, if the patient is not needing intermittent skilled care. So again, remember with Medicare, you're not staffing. The visits that you make are usually an hour or less long, and they're intermittent. So you're not staffing like with a private care or private duty agency. The other form that Medicare will and the surveyor will want to know that you understand is the Home Health Change of Care Notice. It's also referred to the HHCCN form. It used to be that these two forms, the ABN and the HHCCN form, was combined, but about a year and a half or so ago they separated them because there was a lot of confusion with these forms. This form is just what it says. It's to be given to the patient when there's a change of care. Okay, either reducing or discontinuing care to the patient. So you're notifying them the reasons why they're not going to be getting therapy anymore, they're not going to get nursing anymore, you know, whatever that may be. And again, you're going to provide that to the agency, again, whenever that is listed in the POC, and the doctor has changed the order, or there's not a need for that, or you're not able to provide that. Again, that's when you're going to use that notice of change form. The other form that Medicare has that you're required to use is the Notice of Medicare Non-Coverage, or the NOMNC form. What Medicare says, and is one of the conditions of participation, is that at least 2 days prior to the last visit that you make to the patient, that we're going to let them know and give them written notice that they're being discharged from home care. With that notice that we give them, we let them know that if they want, they can file an appeal to their discharge. And with that notice that we give them the name and the phone number of the QIO, or the Quality Improvement Organization, that they can contact and say, you know, who they are, that they're being discharged from ABC Home Care, and that they feel like they're being discharged and they're not ready for discharge. What will happen is, once that appeal has been made, and the patient does this is not something that the agency is required to do. The QIO will contact your office and let you know there's been an appeal for a discharge, and that you need to continue seeing the patient until the appeal is either validated or repealed. So again, it's a pretty quick process. And then, you know, usually it's a matter of them questioning why you're discharging the patient. They may get a hold of the physician and help to understand why the patient's being discharged, and they'll make the determination if the patient is being discharged correctly. Again, you can use this form and you can give it a week, you can give it 2 weeks before the last visit. But don't give it on admission. We've had some deficiencies where this form has been given to the patient on admission. That's not appropriate. And then we see charts where it's not been used at all. So again, if the patient doesn't have it in the chart, then that's going to be a deficiency. There are some situations where you may not need to give the notice of non-Medicare coverage. One of those would be if the patient dies. One is if the patient refuses further visits. One is if the patient is discharged from the physician and the physician doesn't want any more visits made. And another one might be that the patient went into the hospital and you transferred them and never resumed their care. So all of those would be instances when the notice would not be expected to be in the chart. But a regular discharge, we for sure want to see it. And you do have a policy on the notice. So you can read that. It's actually in your patient care policies. So you can be familiar with that. So on that form as well, we provide that to you. We complete it with the name and phone number of your QIO. It's on your thumb drive and in your admission packet. Those QIOs are specific to regions, depending on where you're located in the United States. So we do provide that for you. And there's a copy, it's a 2-copy or duplicate form. One needs to come to the patient's chart in the office and one stays with the patient. So that covers the patient chart. We want you to give us a call in clinical if you have questions, something you need help with. And hopefully this gives you a better understanding of what the chart needs like when we come and visit you. And then we'll audit those charts. We'll audit some charts when we're on site, and then we may also have you make copies and send some to us in the office so we can audit them, even a few more for you if we have concerns. So thank you so much. You guys have a great day, and we will see you soon on the site visit.